It's a privilege to be here. I've been surrounded by so much expertise today, and I'm going to do my best to try to incorporate some of the topics and things that we've heard throughout the day today. I have no disclosures. Our objectives today, I really want to focus on how did we get to where we are. So, the concept of antibiotic resistance, long durations of therapy, short durations of therapy, what guided this and how did this culture become to be, essentially. So I'm going to review the evidence around those ideas and also try to provide, robust evidence for shorter durations of therapy for common conditions. So to begin, I think we all understand the impact and importance of antimicrobial stewardship, antimicrobial resistance, but it's such a complex topic, and I really like how some of the quotes on this slide go about it. So first, why we must and how we can. So this is referencing a paper from Arjun Srinivasan with the CDC from 2017. And if you haven't read that paper, I encourage you to look into it. But essentially, he talks about, why do we need to care and how can we care? The reason that I love antimicrobial stewardship is because it's something that affects all of us. It's a global problem. It's in some ways you could perhaps say it's analogous to climate change. It requires us to think beyond narrow self-interests. To quote Dr. Ramanandan, when we overuse antibiotics, others have fewer options to treat infections. If we pollute the environment, those downstream from us may get sick. A problem like resistance is challenging because it requires cooperation on different scales from clinicians, communities, hospitals, healthcare systems, states, countries. So today I'm focused on clinicians and how we can do our part because improvements anywhere can lead to impacts everywhere. So I want to begin with a group question. You don't need to raise your hand or anything, but I want you to think about this because I'm going to go through all of these points to kind of illustrate why they're either correct or why they're wrong. So shorter courses of antibiotics for common infectious diseases are associated with which of the following? Increased adverse events, increased risk of antibiotic resistance, decreased cure rates, or decreased risk of antibiotic resistance. All right, so to get into it, so historically, public health agencies have created messaging that perhaps has created some of the biggest problems because one of the most difficult concepts of resistance is that prolonged courses of antibiotics have considered to be a solution rather than a cause of resistance. Early CDC and public health messaging and other agencies designed to educate the general public and clinicians about antimicrobial resistance often alluded or said that patients should finish their entire course of their prescription because if they don't, there's a chance that it could lead to antimicrobial resistance or treatment failure. So, while this is good advice when you want the patient to take their whole prescription and to be adherent and to perhaps not misuse that drug at a future point, it's actually really bad advice if you want to prevent resistance and also adverse events. The concept of finishing the antibiotic course to prevent resistance may apply to infections for which treatment is expected to eradicate the causative bacteria. So think about like gonorrhea, tuberculosis, things that really don't belong in the body. But it does not apply to infections caused by normal body flora. So, most of our common clinical conditions, upper or lower respiratory tract infections, urinary tract infections, intra-abdominal infections, in which the bacteria will persist long after the signs and symptoms of infection have resolved. So I know personally I have been guilty of probably sharing this fun comic that I think that we have all seen. I think it pops up around Halloween every year. Beatrice, the biologist, who says, what are you supposed to be? Unfinished course, I'm scary, I could be causing a resistance. So, this isn't really correct, so I fixed it. So I said, what are you supposed to be? A unnecessarily long course of antibiotics, and I can lead to antibiotic resistance and side effects. Aren't I terrifying? So, this is the more true messaging that we need to understand, and I'm going to go through the evidence as to why those things are true. So cross that out, and we need to re-educate. So in reality, any antibiotic exposure, even a short duration of antibiotics, can lead to resistance. So historically, ever since penicillin has been around, we've known that there's an association of antibiotic use and resistance. However, there has not been a strong study that has shown a causal relationship up until this study right here, which was really interesting. It was published in the Lancet in 2007. So it was a double-blind, randomized controlled double-blind, placebo-controlled randomized trial looking at the use of two different macrolides, azithromycin, dosed 500 milligrams times 3 days, or clarithromycin, 500 milligrams BID times 7 days. And they wanted to look at the impact on resistance. The primary outcome was the change in proportion of strep pneumo that were macrolide resistant. So what they did is they got swabs, they swabbed people's throats, they cultured them, they sequenced them, trying to look at both microbiome, like phenotypic, but also genotypic kind of changes in those organisms. And they got those baseline cultures at day 0. You'll see that there's already about 30% prevalence of resistance in this population. Interestingly, they did exclude any patients that had any sort of antibiotic exposure in the previous 2 months, but this just shows that even in 2007, about 30% had a baseline flora that was resistant. So then they got a culture 24 hours after the end of therapy. So for azithromycin, that was day 4. So if you follow the blue box and you go to day 4, it went from about 30% to about 90%. So it tripled in resistance. If you go to the clarithromycin arm, day 8 would have been 24 hours after the end of that therapy. Again, it about tripled. And then the really interesting part is that this resistance was sustained and endured for up to 6 months. So they sampled these patients at day 14, day 28, day 42, day 180. And even though that these are 2 different drugs, macrolides, they had their own unique selective pressures. So azithromycin technically caused more percentage in resistance, but clarithromycin caused more genetic mutations that could confer higher levels of resistance later on. So essentially what this study showed was that even a short course of antimicrobial therapy can lead to antibiotic resistance. So one could say then, well, why should I even care about duration? If after 3 days, if they get antibiotic resistance, then why would a longer duration really affect this? And the simple answer is that it's complicated, but generally antibiotic use drives selective pressure. So the belief that prolonging antibiotic durations prevents resistance is probably mostly misunderstood to the broad effects that antibiotics have. With rare exceptions, antibiotics broadly affect bacteria in our body. After each dose, this prolongs the exposure, in which many of the species in the human microbiota, not just for that particular pathogenic organism, leading to infection. This exposure selects for resistance that then colonizes and prolongs the exposure, increases the likelihood that their dominance will increase. So it's complex, and some antimicrobials perhaps have a stronger barrier to resistance. We think about drugs like vancomycin and Staph aureus, which has been our workhorse for 40 years, perhaps has a higher barrier to resistance. But no matter what, all these drugs do have some broad effects and likely can alter the flora, increasing our pressure for resistance. We do have some clinical trials from the early 2000s that helped prove this point. So, even in the early 2000s, we were starting to question duration and whether or not it affected efficacy outcomes, but also resistance outcomes. So, multiple HAP-VAP studies. These are typically some of the sickest patients in the hospitals. The top trial was from Respiratory Critical Care in 2000. They looked at HAP-VAP, ultra short duration from 3 days versus 10 plus days, which was considered the standard of care at the time. And they saw that the resistance in MDROs increased from 15 to 35%, with no difference in mortality or length of stay. The next study was published in 2003, very similar to the previous one. Again, a VAP study, which showed increased MDOR carriage from 42% at 8 days to 62% in 15 days with equal cure. And then the last study, which is similar to the previous study that I mentioned, high-dose amoxicillin, nasopharyngeal penicillin-resistant strep pneumocarriage increased from 24% to 32%. So, we're not seeing the tripling effect, again, different drug class, but resistance still increased, and it increased at a significant amount after a longer duration. Additionally, throughout today, we have heard that, some of the most powerful messaging that we can have as stewards is that, antibiotics can cause harm. This was a really interesting and very popular meta-analysis that's been widely cited and widely promoted since it was published in 2022 by the Public Health Ontario group. This visual abstract, I think, is really amazing because it basically summarizes all of their outcomes. Whenever I'm thinking of stewardship, I usually mention this. Every single day of additional therapy is going to increase adverse event rate by 4%, antibiotic resistant rate by around 3%. If we think of a 3 versus a 5 day duration, 9% increase in odds ratio, 7 versus 3 days, 19% increase in odds ratio. So every time I approach a duration of therapy, I'm thinking of, is there a way that I can decrease the risk of harm while ensuring that clinical efficacy is maintained? So now that we've gone through a little bit of the basic science of how resistance works, how did we get to where we are? I want to give Dr. Kelly Bork some slide credit. She's from KU and also with the Kansas Health Department. She has given some excellent presentations on the history of antibiotics, but I think that this is really interesting to see how did culture develop and how did the dogma develop. So starting way back in the 1940s when penicillin first came around, in general, most patients were treated with 1 to 2 days of penicillin, and that was enough. That was shown to achieve satisfactory results with 1 to 2 days for community-acquired pneumonia. Most patients were treated for 3 to 4 days. There was a case of staphylococcal sepsis or bacteremia in the 1940s in which they had to extract the penicillin from the patient's urine because they only had so much, a day's supply of penicillin, and that after they ran out of penicillin, the patient did succumb to their infection and had mortality at around day 4 or 5. So then that brought up the idea of, well, there's no evidence that resistance occurred, but perhaps we need longer durations of therapy to treat. For the pharmacists in the room, we have all been quizzed on various law exams throughout pharmacy school and beyond about, some of the scandals that have occurred throughout history, which then promoted various laws, the Kiefer-Harris Amendment in the 1960s. But a lot of this revolved around scandals and then also patient harm events. So really interesting history. In the 1960s, the FDA director of antibiotics was involved in a large scandal with pharma promoting antibiotic durations. During this time, the industry promoted heavy use, and there's pretty much no evidence for durations of therapy. Companies profited by selling more antibiotics for longer durations. By the 1990s, early 2000s, guidelines and professional societies started questioning durations. IDSA stated in the, I believe it was the 1990s CAP guidelines, we are not aware of any controlled trials that specifically address how long pneumonia should be treated. In traveler's diarrhea, 1 day appears to be equally effective to 3 days. For meningitis, 7 to 21 days. Duration is based more on tradition than evidence. In 2008, Dr. Rice gave a conference on antimicrobial resistance, and essentially what he advocated for is we're not going to be able to stop all the antibiotics, but what we should really focus and prioritize some of our efforts on is shortening our durations of therapy when appropriate based off of randomized controlled clinical trials to decrease pressure and thereby decrease resistance. And that has led to 20 plus years of duration studies that have shown short durations for UTI, gram-negative rod bacteremia, CAP, VAP, skin soft tissue, osteo, septic arthritis, sinusitis, neutropenic fever, malaria, that the conditions just keep expanding as we gain more insight. So this history helped inform culture. So I like to refer to this quote down here. This was from another expert in the field, Dr. Paul Sachs, but he was commenting on a patient question. I understand why I needed to complete the full course. What I didn't understand was why a full course took precisely 7 days. Why not 6, 8, or 9.5? Did the number 7 correspond to some biological fact about the human digestive tract or the life cycle of bacteria? And in kind of a tongue-in-cheek approach, both Dr. Paul Sachs and another expert in the field, Dr. Brad Spellberg, said, 6 is inherently weird, so you wouldn't do that. We have 5 fingers on a hand, we have 7 days in a week. If we were 3-toed sloths, it would probably be 3, 6, 9 day durations. If our number of days in a week was 4, we would have 4, 8, 12 day durations. So it really is arbitrary, but this has really created a culture around why we do these durations of therapy. And it's hard to change. This has led to the shorter is better mantra, which I would say comes from fear of undertreatment to harm from overtreatment. So that's kind of the messaging, that we need modern trials to challenge historical dogma to establish new standards of care for durations of therapy. To quote Dr. Buddy Creech, who is a pediatric infectious disease physician, we're looking for that Goldilocks amount and duration of antibiotics that treats the infection but does not overtreat it, so that we can avoid side effects and changes to the healthy germs that are there. So some of the sayings, Public Health Ontario and Canada, they like to use shorter, smarter. My personal favorite is just enough is better, or it's okay to stop when you feel better. So this comes to the question, can you stop when you feel better? So this is kind of the basis of clinical trials looking at the duration of therapy. So kind of at the base of the pyramid, we have to have that the antibiotic treatment is actually indicated for the correct diagnosis. So we've talked a little bit about, previous speakers have talked about, misdiagnosis. You have to have the right drug, dose, frequency, compliance. Symptom resolution needs to be an indicator of cure for condition. And all of this will inform a clinical trial to evaluate the safety and efficacy at stopping at predefined clinical endpoints. So this is really important, such as symptom improvement and safety outcomes like recurrence mortality. Lastly, we have guidelines that then can recommend durations that reflect a regimen likely to be successful in most cases. So, greater than 90% of patients. New Zealand has done a lot of great shorter is better work as well, and one of their leading physicians has said, there is absolutely no risk and every advantage in stopping antibiotic therapy immediately after a bacterial infection has been excluded or is unlikely. Again, the whole argument around durations of therapy is probably whether or not therapy was indicated in the first place, and minimal risk if signs and symptoms of a mild to moderate infection have improved or resolved. I do want to mention some criticisms. There are some great commentaries published in response to a lot of the shorter is better papers. And I think that these things are all valid, and I always recognize them when a physician brings it up. So, response to therapy is likely dependent on a range of host pathogen drug-specific factors. And that's true. Medicine's complex. All of our patients are different. The drug that we're picking, the dose, the frequency, the renal function, the body habitus, if they're obese, all of these things could perhaps play a role. They say that prospective trial-based set durations, even if reassuringly short, oversimplify real-world data. Another paper suggests clinicians should appreciate the sometimes limited inclusion criteria when incorporating clinical trial data into their practice. So this is when I get the answer, well, my patient doesn't look like the patients included in that trial. Perhaps they're sicker, perhaps something's different about them. But at the end of the day, what I think that we need to remember is that they're not advocating for a fixed short duration for all, but a cultural change from arbitrarily long fixed durations, utilizing the best available evidence to offer individualized patient care, which often does encompass the vast majority of our patients. I'm now going to go through some of the common shorter is better conditions. So there have been more and more other societies that have been publishing their own guidelines, really re-advocating for shorter is better. So IDSA is probably the backbone. However, we have the GOLD guidelines for COPD. 5 days has been recommended for a while now. Community-acquired pneumonia guidance, UTI, and cellulitis. So I'm going to go through some of these common ones to try to illustrate how robust the evidence actually is for these conditions. So to begin, for CAP, so this includes adults and pediatrics. So I've made a special process to include pediatrics in this because although they're a different population, a lot of these principles are also true in that population. So there's over 14 randomized controlled trials, including 8,000 patients, showing that 3 to 5 days or short duration is non-inferior to 5 to 14 days or long duration of treatment in patients who have met clinical stability criteria. So this is the 3-day randomized controlled trial. They looked at 3 days of a beta-lactam versus a longer duration of therapy. The results in the bottom box, so this was the primary outcome of cure at day 15. It was, I believe it was a composite outcome. And then they stratified those results based off of age and then also PSI score, which is pneumonia severity score. So even among some of the patients with the highest severity scores, it still favored a 3 days of beta-lactam regimen over a longer duration of therapy. Dr. Vaughn had mentioned this, that, the vast majority of patients probably could be defaulted to a 3-day duration of therapy. And this was a robust study that was done. It didn't make its way into the IDSA guidelines because it was published after the fact. However, there's at least one tool that has incorporated some of this newer evidence that I'll mention near the end. For shorter is better for UTI. So again, including adults and pediatrics, we have over 11 RCTs, including 2,600 patients. Complicated UTI, 5 to 7 days of antibiotics are non-inferior to 10 to 14. And then paleo, 5 to 7, non-inferior to 10 to 14 days. Some will argue that the caveat here is that the drug of choice matters. And I would say that the drug of choice needs to be optimized from a PK/PD perspective for that patient. There's more evidence coming out to show that, even amongst our beta-lactams, which perhaps lack some evidence for shorter durations of therapy, and urinary tract infections are probably adequate even for a short duration when the dose is optimized. So the top trial here is from ASHE from a year or two ago. It was a retrospective cohort study, so not the most robust level of evidence. However, they showed similar outcomes amongst patients who got 3 days of Rocephin versus patients who got longer, more standard courses of treatment. So I like to reference this study as a harm reduction measure, showing that, even at 3 days of antibiotics, kind of similar to 3 days of fluoroquinolone or Bactrim, on which you have very high concentrations of drug in the urine, you're likely to achieve clinical cure. The next one that I want to mention, now this is actually a really old method, but aminoglycosides for the treatment of UTI. This is a one-time dose. It's somewhat being resurrected as resistance rates are increasing. Dr. Ashroff and Dr. Price were mentioned earlier, in some parts of our state we have 30% ESBL, and that starts really limiting our oral options because when we have an ESBL isolate, it often also confers Bactrim, nitrofurantoin, fluoroquinolone resistance. So when you give a low dose of aminoglycoside, you get very high urinary concentrations for the first 24 hours and then maintain bactericidal concentrations for several days thereafter. The last condition is skin soft tissue infections, which is kind of a weird one, and this one's a little bit harder to nuance just because skin soft tissue stuff and dermatology things generally is really hard. But there have been 4 RCTs of 1,400 patients showing that generally 5 to 6 days of antibiotics is non-inferior to 10 days for non-purulent cellulitis. There's one trial called the DANCE trial that was published relatively recently that showed that perhaps it was not non-inferior. However, there are quite a few issues with that trial, and most say that the results need to be interpreted very cautiously. This is a picture of just our local guidelines at UNMC, in which we recommend an short duration for most patients of 5 to 7 days. The age-old question that I most frequently get asked, and I think this is a really hard question from a stewardship perspective. So my patient has been on effective therapy for 48 to 72 hours, but they don't seem to be getting better. Their skin still looks bad, their leg, it's still swollen, it's red. What are we doing wrong? Is this therapeutic failure? I always say that we should be reassessing. So these boxes on the right, is it the wrong bug, wrong drug, wrong diagnosis, wrong host, or lack of source control? Wrong diagnosis, I think, is a one that really gets us a lot. And as a pharmacist, I do not diagnose, but I certainly review the patient's chart. And if they're there with a CHF exacerbation and they have pulmonary edema, versus a community-acquired pneumonia, those are certainly things that we can help figure out as a pharmacist and to help guide our prescribers. Lack of source control is the next big one. So let's say they have community-acquired pneumonia, but they have an extrapulmonary infection, empyema, large pleural effusion, et cetera. Perhaps those patients would take longer to get better and would need other interventions. The other thing that I like to think about is wrong drug. Do they have paleo and we put them on nitrofurantoin? There's lots of kind of reasons that perhaps they're not improving, but usually I think that it's one of these problems that we can identify. So to speak towards inappropriate diagnosis, so I was really glad that Dr. Vaughn mentioned this. I don't know if she's here, but she could speak to her paper better than I could. But however, it was a really interesting study looking at a group of hospitals in Michigan. Again, the definition of pneumonia that they used was somewhat broad, so it's likely an underestimation. About 1 in 8 patients were inappropriately diagnosed, but most still received a full course of antibiotics, and this was associated with adverse events in those patients. The next one I like to mention is bacteremia from a presumed urinary source. This was also hot off the press last month. 7 in 10 patients with asymptomatic bacteria received antibiotics, even though they probably had less than a 2% risk of actually having bacteremia. They identified ASB, but they still got treated. And then for cellulitis, this paper at the bottom, I really like this one because it's just myths, but about 40% of cellulitis is misdiagnosed. Do they have venous stasis? If we elevate their leg and wrap it, does it get better? These are all good questions. And what I want to emphasize here, the debate around stopping antibiotics early is about ensuring that antibiotics are started appropriately in the first place. I think one of the most impactful interventions that we can do as stewardship is recommending to stop antibiotic therapy if it's not appropriate for the indication. Others before me have mentioned that diagnostic momentum that occurs. However, from a stewardship perspective, this is why we exist, to take an objective look at that chart about that patient and ask the question, do you think that the patient, this is indicated? When longer durations are needed, so it's not always, shorter is not always better, and there are situations in which longer durations could be needed. Deep-seated infections, those without source control, infections in which microbiological eradication is the goal, so infections like TB. These often require discussions between prescriber, patients, tailored approaches to plans of care. So this is just a disclaimer that not everybody will qualify, but are common clinical conditions, those 3 I just mentioned, and certainly others. So initiatives to improve durations. There's lots and lots of things we can do, but the most effective interventions are usually multifaceted. So this includes EHR, audit and feedback, and guidelines, and incorporation in clinical decision support, or like checklist systems built into your EHR. I'm going to talk mostly about guidelines because I think that guidelines really form the foundation and backbone of most stewardship interventions. You can call these a lot of different things: guidelines, care standards, expected practices. But essentially what they do is they help shift the sense of medical legal responsibility from the provider to the institution and provide psychological reassurance when standards change. So, you don't want to be worrying at night, and having a clear-cut guideline that your institution supports as the standard of care can help provide that reassurance. Additionally, it serves as the backbone for education, prospective and audit feedback interactions, and clinical decision support checklists and order sets that can then be made around your local guidelines. Just referenced a paper here, Harnessing the Electronic Health Record to Improve Empiric Antibiotic Prescribing, which is an excellent paper showing the impacts of clinical decision support systems based off of guidelines. Also important to mention, having and adhering to guidelines is a regulatory requirement, so then you get to check multiple boxes at once. A few examples of shorter is better, so CAP clinical pathway from IDSA. They're also coming up with a UTI pathway. They did incorporate the 3-day duration in there if you're clinically stable. Coming from Utah originally, I'm a huge fan of Intermountain's care process models. They just recently published a 2024 community-acquired pneumonia in adults pathway that does help guide duration of therapy and their patients as well, showing that if they meet clinical stability criteria, 3-day duration being appropriate. Certainly Nebraska Medicine and UNMC also has a lot of resources that can be adapted to local guidance. Dr. Kites recently created our AmCare-focused pathway for UTI, again, recognizing shorter durations of therapy being appropriate for most patients. So, now that we've had time to kind of go through this, you can probably reflect on what the correct answer is, but essentially, the only thing that is true is decreased risk of antibiotic resistance. You do not see an increased risk of adverse events, increased risk of antibiotic resistance, or decreased cure rates for common clinical conditions when using a shorter course. So in conclusion, I believe that one of the most impactful things that we can do is in stewardship, one of the interventions that we can make is shortening or stopping durations of therapy when appropriate. This does not increase the risk of antibiotic resistance, is generally considered a very safe measure in patients who have clinically improved, and can lead to harm reduction. All right, so that is all I have. I would be happy to take any questions or comments.